Hello, everyone. Thank you for joining us today for our webinar, Starting Your Practice in Ontario, a Beginner's Guide to OHIP Billing Codes. Let me start by introducing myself. My name is Daniel Brenner, and I am the Senior Director of Operations at Doctor Care. It's great having everyone join us today. To jump right in, whether you're just starting out as a family physician, planning your move to Ontario, or considering a transition to a new payment model like the FO, Ontario offers so many opportunities for physicians. With a growing demand for family doctors and the supportive structure of the FO model, it's truly a great time to set up your practice here. However, we also recognize that getting started can feel somewhat overwhelming, particularly when it comes to understanding the intricacies of OHIP billing, which is why we're here today. In this final session of our two-part webinar series, we'll walk you through the fundamentals of billing under the FO model, understanding the distinction between in-basket and out-of-basket billing, what to consider when billing for non-rostered patients, and a breakdown of the codes you're billing for. We'll cover important sections, including the difference between assessments and consultations, after-hour codes, virtual care, weekend access, chronic disease management for diabetes, smoking cessation, heart failure, mental health care, and much, much more. We'll also share the proposed billing changes introduced by the Ministry of Health and the OMA for the FO Plus model that may impact your day-to-day practice. If you missed the first part of our webinar, we highly recommend watching the recording available on our website as we discuss important topics for getting started in the FO model. Before we dive in, just a quick note. We'll be keeping this session to about an hour and we'll leave time at the end for questions. And as a thank you for joining us today, we'll be sending you a complimentary copy of our 2025 Comprehensive OHIP Billing Guide. To begin, let me introduce you to Doctor Care. Many of you are already familiar with Doctor Care, but for those who aren't, we are the largest provider of billing and practice support to over 4,000 physicians across Canada. On average, we have helped doctors recover $25,000 to $30,000 of revenue per year. We also support approximately 25% of all FOs in Ontario. Our solutions and services are designed to help doctors optimize their practice, maximize their revenue, and improve patient care. Just some webinar logistics. All attendees are in listen-only mode. We are recording this webinar, so it will be available to you after the event. If you have any questions during the webinar, please submit them in the Q&A feature, and we will try to answer them either at the end of the webinar during the Q&A session, or if we are unable to answer your question, one of our team members will follow up with you after the webinar. So before we get started with an introduction to the basics of FO billing, we wanted to jump into the hot topic of the changes to the FO model. With the Ontario Physician Services Agreement having expired in 2024, we have been closely watching ongoing negotiations between the OMA and the Ministry of Health. The latest proposal introduces an exciting new concept, the FO Plus model. The proposed agreement was sent to arbitration on June 30th, and a ruling is expected this fall. Whether you are currently practicing in a FO or are considering joining or transitioning to FO, you need to understand how these proposed changes could impact your practice operations and compensation. The FO Plus model is a proposed update to the existing FO payment structure. It is not a full redesign, but rather an effort to address some of the long-standing gaps in physician compensation. It also aims to reduce some of the administrative complexity that makes running a medical practice more challenging for many doctors. One of the most significant changes is the removal of access bonus. This means physicians will no longer be penalized for patients visiting walk-in clinics or worry about monitoring outside use. The other item the ministry is removing is the comprehensive care capitation payment. This is a small amount of payment that comes from a faux doctor's capitation. On average, it's about 1/5 the amount of your total capitation payment. As to what is increasing in this new model, most in-basket codes will see increases to 30% of the full fee-for-service rate. Select procedure codes will receive even higher increases to 50% of the fee-for-service rates. The after-hours premium will increase from 30% to 50%, providing better compensation for physicians who provide extended care to their patients outside regular business hours. The Group Management Leadership Program, or GMLP, will be increased up to 4 times the current rate, providing better compensation for physicians who take on leadership roles within their FOs. Lastly, in-basket services performed in a hospital setting will be considered out of basket and paid at the full fee-for-service rates, ensuring that physicians receive appropriate compensation for hospital-based care. Perhaps the most groundbreaking change is the introduction of hourly payments at $80 per hour, billed in 15-minute increments with a maximum of 14 hours per day. This covers 4 distinct categories of work. Direct services, which is time spent directly with patients. A direct telephone, which is phone consultations and is paid at $68 per hour instead of $80 per hour. Indirect services, so these include things like charting, reviewing lab results, billing, and other administrative tasks. And clinical administration, which are things like roster management, chronic disease patient management, and other clinical oversight activities. There will also be increases to patient attachment fees, additional codes for Healthcare Connect, as well as increased flexibility to establish and maintain FO groups. With all these major changes happening, we have created a blog available on our website that covers everything you need to know about the FO Plus model and how it could affect you and your practice. Of course, you can expect a webinar in the future about all upcoming changes as they become confirmed. So with that, let's dive into the FO billing basics. Under the FO model, physicians can bill codes that are either in basket or out of basket. In basket codes include services that physicians provide to their rostered patients. These include things like general assessments, minor assessments, some consultations, counseling, and so on. Since physicians are paid through capitation for their rostered patients, they are paid 19.4% of the fee value of an in-basket service. In a FO, there is a restriction that currently sets a group hard cap of approximately $63,639 per physician on in-basket services provided to non-rostered patients. So it's good to keep this in mind when you're providing these in-basket services to non-rostered patients. Out-of-basket codes are services that are not included in the in-basket services and, therefore, are paid at 100% of the service's value. These include services such as repeat consultations, reassessments, certain group counseling, form completions, disease-specific counseling like diabetes, congestive heart failure, palliative care, and many, many more codes that we'll be covering a lot of them today. Billing the appropriate out-of-basket codes for the services you provide is important in ensuring that you are paid for the full value of the service. Doctors miss out on higher revenue potential when billing an in-basket code for their rostered patients when they could have billed the appropriate out-of-basket code instead. Let's review some of the key definitions that will help you understand the codes we'll discuss later in this webinar. Assessments are encounters with a patient in which a history is taken and a physical exam is performed. Assessments, for the most part, can be provided virtually and physically at a place other than in a patient home. Counseling is a patient visit dedicated solely to an educational dialogue with a patient. Many of these codes are timed and can only be billed if physicians complete the required time allotted for these services. Consultations are assessments requested in writing by a referring physician who has professional knowledge of the patient and identifies the consultant physician as competent to give advice. Let's begin by introducing some of the most common in-basket codes. These codes are associated with services that physicians must offer to their rostered patients as part of their patient-physician relationship. Physicians receive 19.4% of the fee value for each in-basket service they provide. The first in-basket codes that we'll cover are some of the common assessment codes. The most common assessment codes that we see physicians bill in their daily practice are minor assessments, A001s, intermediate assessments, A007s, and general assessments, A003. A001 is an assessment that includes a brief history, an assessment of the affected area, or brief advice or information regarding health maintenance, diagnosis, treatment, and/or prognosis. A007 is an assessment that requires more than a minor assessment, involving 1 to 2 pathologies and examination of the affected regions, but not as comprehensive as a general assessment. In contrast, an A003 requires a full history and examination of all body parts and systems and may include a detailed examination of one or more parts or systems. These do not include breast, genital, or rectal examination and are limited to one per patient per physician per 12-month period. Let's explore an example of a patient assessment. A patient comes in for the first time to see the doctor regarding an ongoing headache. You take the patient's blood pressure, examine the patient's eyes and other body parts, and review their full medical history. Would you bill an A007, A001, or A003? If you chose A003, great job. Because the doctor is completing a full visit with a new patient, including a physical examination and a review of the patient's full medical history, you would bill the general assessment code, A003. Looking at one more example, a patient comes into your clinic representing flu-like symptoms. You perform a focused history and a physical to assess the patient's systems and identify any problems or complications. Again, would you bill an A001, A007, or A003? You would bill the A007 intermediate assessment based on the services provided. In the same category, we have periodic visits, or as they are commonly known as annual physicals. These codes are used for age-based visits performed after a patient's second birthday, rendered to patients who present with no apparent acute physical or mental illness. These visits are represented by specific K codes depending on the patient's age for periodic visits. The K017 for children aged 2 to 15, the K130 for adolescents aged 16 or 17, the K131 for adults aged 18 to 64, K132 for adults aged 65 and over, and the K133, which is for adults with intellectual and/or developmental disabilities. We often see physicians confuse billing annual physical codes with A003, which would be incorrect. These K codes are meant specifically for patients' annual physicals, whereas the A003 is meant for when a patient comes in with a specific problem that requires a full exam and review of medical history. We have created a guide on the difference between assessments and consultations, which can be a valuable tool in your practice. You can find this guide in the resource library on our website. Earlier this year, Ontario Health made a major change to cervical cancer screening. The Ontario Cervical Screening Program has transitioned from PAP tests to primary HPV testing to better identify those who are at high risk for cervical cancer. This shift enhances early detection and reduces unnecessary testing for individuals at low risk. What does this mean for you in terms of seeing your patients? Here are the most important changes made to the Ontario Cervical Screening Program. Screening now begins at age 25 instead of age 21. Those who test negative for HPV will have longer screening intervals, which will be every 5 years instead of every 3 years. HPV testing will also be used in colposcopy to determine eligibility for discharge and post-discharge screening intervals. Regarding the existing codes, let's go through them. G365 is a routine procedure for the collection of cervical cancer screening specimens. From our experience, we noticed that many physicians are not aware that the G365 code is not eligible for payment when performed in conjunction with a consultation, repeat consultation, general assessment, or postnatal visit. The code is payable with an intermediate assessment and periodic visit. Additionally, when the collection is performed outside of the hospital, you can bill the E430 tray fee code. You will bill the fee code G395 for any additional cervical specimens taken in the case the first sample came back abnormal or inadequate. The tray fee that can be billed alongside the G394 is the E431. These billing codes haven't changed, but now have new descriptions to address the specific screening taking place. Concerning the G365 billing frequency, the updated guidelines are as follows. G365 services provided between March 3rd, 2025 and March 31st, 2028. G365 is limited to once per patient within a 33-month period. For G365 services provided on or after April 1st, 2028, G365 is limited to once per patient within a 54-month period. To learn more about how to bill the HPV test codes, you can refer to the blog post available on our DoctorCare website. So let's take a look at an example. A patient comes into your clinic for an HPV test. The results come in, and the doctor requests the patient to come back in a couple of months later for a retest. What code or codes would you bill for the second HPV test? I'll give everyone a second. Because the patient must come in for a retest shortly after their first HPV test, they cannot bill the G365. Instead, they bill the fee code G394, along with the tray fee code E431, because it was performed outside the hospital. On the other side of patient visits, there are consultations. These are assessments requested in writing by a referring physician who has professional knowledge of the patient. The most common consultation codes we see billed are the A005 consultation, the A006 repeat consultation, and the A905 limited consultation. A005 is our consultation code, which includes the services necessary to prepare a written report performing a general, specific, or medical specific assessment, and the review of all relevant data. A006 is the additional consultation by the same consultant for the same presenting problem. A905 is the service rendered by any physician who is not a specialist, where the service meets all the requirements for a consultation and is less demanding in terms of time than an A005. Now, let's take a look at counseling codes. The K013 is a patient visit dedicated solely to an educational dialogue with a physician and is offered to raise awareness of the patient's problem or situation and modalities for the prevention and/or treatment and to provide advice and information. K013 is considered a time-based billing code. It requires a minimum of 20 minutes spent counseling the patient, and you can claim additional units based on the total time. The chart here provides a breakdown of how it works. Additionally, K033 is an out-of-basket counseling code that can be billed after the K013 counseling code has been billed 3 times for the same patient, while K040 and K041 are both group counseling codes, with K040 being billed the first 3 times and K041 being billed subsequently after. We will cover more time-based billing codes in our mental health care section. So let's go through a counseling example. A physician spends 20 minutes for the first time providing knowledge and information to an enrolled patient about family planning. What code do you bill? Because the physician is providing education to the patient on a topic, they will bill a counseling code. Since counseling codes are time-based, we need to build a code that fits within the unit requirements. Based on the table in this slide, the 20 minutes falls under 1 unit. So you would bill 1 unit of the K013 code for this visit. Mental health care is an essential part of many physicians' practices, whether through scheduled visits or conversations that arise during general appointments. Without a strong understanding of mental health billing, it's easy to miss eligible codes and leave revenue on the table. Here are the most common mental health codes physicians will encounter. K005. This is the primary code for mental health visits for individual care and is payable for visits where physicians provide advice and information regarding diagnosis, treatment, health maintenance, and prevention. It is a time-based code that requires a minimum of 20 minutes of direct patient contact. K007. This service is any form of treatment for mental illness, behavioral maladaptations, and problems assumed to be of an emotional nature, with the purpose of treating existing symptoms and/or behavioral patterns. Like the K005, it is a time-based code that requires a minimum of 20 minutes. And lastly, the K623. This code is an out-of-basket code and would be billed when a physician completes the Form 1 application in order for a patient to receive a psychiatric assessment. The application for psychiatric assessment in accordance with the Mental Health Act includes necessary history, examination, and notifications of the patient, family, and relevant authorities. By familiarizing yourselves with these codes and the requirements associated with them, you can not only optimize your practice revenue, but also enhance the quality of mental health support offered to your patients. Let's switch gears and discuss long-term care billing. In part 1 of our webinar series, we talked about the different areas of care that physicians can participate in to earn special bonuses, one of them being long-term care. When it comes to long-term care billing, Patients in LTC facilities are subject to different billing rules as they are not seen in a normal clinic setting. To roster LTC patients, you will bill the rostering code Q202 instead of Q200. If a patient was rostered previously with a Q200 or a Q202 with another physician, the Q202 build will override it. Physicians can also choose not to roster their long-term care patients and see them on a fee-for-service basis. But keep in mind that you would not receive capitation or special premium bonuses for those long-term care patients. In these settings, W prefix codes are the most common billed for long-term care consultations and assessments and are defined as services applied to patients in chronic care hospital, convalescent hospitals, nursing homes, homes for the aged, and designated chronic or convalescent care beds in hospitals. One of the most common codes we see billed is the W010, monthly management fee. This fee is for routine medical care, management, and supervision of a patient in a nursing home or home for the aged in one calendar month and requires a minimum of 2 assessments of the patient each month. Although it is common for physicians to bill W prefix codes for long-term care patients, they are not limited to these billing codes when they visit them. If the patient has a chronic illness, such as diabetes, congestive heart failure, you can bill the K030, K029, or Q050, which we will touch on later with the respective diagnostic codes. Now let's move on to virtual care billing. In response to the COVID-19 pandemic, the ministry introduced a new virtual care funding framework. This framework requires physicians to bill the fee codes under comprehensive virtual care services and limited care services. By now, you might be familiar with these, but if you're just starting out as a new physician, here's what you need to know. Let's start with defining some terms. Comprehensive virtual care services are services that can be billed if the patient has an existing or ongoing patient-physician relationship. This means that the patient is enrolled with a provider or the provider's faux colleague, or the patient has been seen in person over the past 24 months. The codes are listed in Section 1, Appendix J of the Schedule of Benefits. On the other hand, limited virtual care is a service billed for patients who are not enrolled and have not been seen in person. These two codes are listed in Section 2, Appendix J of the Schedule of Benefits. Now, in terms of payment, the amount paid for each service differs between comprehensive virtual care services and limited virtual care services. When a patient has seen the doctor in the last 24 months for an in-person visit or is enrolled with a faux physician and the service is provided virtually, the modality indicators codes K300 for video and K301 for telephone are added to the patient's visit fee codes. These codes are paid at 100% and 85% of the fee code value, respectively. However, there are some exceptions. The K007, K005, which we covered before, and the K197 and K198 codes using the telephone will be payable at 95% of the corresponding in-person fee. If the patient is not enrolled and has not been seen in person, and if the service is provided virtually, you would submit one of the two fee codes, A101 for video and A102 for telephone. These codes are paid out at $20 and $15 respectively. Please note that for faux and fin physicians, these codes will be paid at the in-basket rate, 19.41%, for rostered patients and full fee-for-service rate for non-rostered patients. Now that we know how to bill for these codes, let's look at a couple examples. First example, a physician conducts a video assessment of a patient for a minor assessment who is not enrolled with them. Additionally, they have not been seen in person within the past 24 months. What would do you bill? Since the patient is not enrolled and has not been seen in the past 24 months, you can only bill the limited virtual care service codes, A101 for video at $20. Looking at a second example, the physician is making a telephone call for a minor assessment on an enrolled patient. What should you bill? Because the patient is enrolled, you would bill one of the codes listed under the comprehensive virtual care service. For a minor assessment, we would bill the A001 along with the modality code K301 to indicate that the visit was completed via telephone. Since the physician is a faux physician providing in-basket services over the telephone to an enrolled patient, they will be paid at 19.4% of the 85% of the fee submitted. So that means the physician will be paid $4.61 for this service. When aiming to provide comprehensive virtual care rather than limited virtual care, it is important to make sure that your active patients are either on the roster or have been seen in the last 24 months. If you need any support with reconciling your roster, we can help. We can do a roster reconciliation to close the gap on rostering active patients that may have fallen off your roster. Feel free to contact us after the webinar and we can help. Now that we've covered the main in-basket codes, let's explore some of the most common out-of-basket codes, which are important for optimizing your revenue. Here's a topic that comes up a lot from physicians. Chronic disease management is a key part of every family physician's practice. Conditions like diabetes, congestive heart failure, smoking cessation, and others requiring continuous monitoring, patient education, and support, and are part of the ministry's incentivized division of payments. In the faux model, these visits offer valuable billing optimization opportunities through specific codes and premiums that recognize the added time and complexity involved in managing chronic conditions. Yet, many physicians may be unaware of these billing codes, which result in missed claims and unrealized revenue potential. In this section, we'll focus on three primary categories of chronic disease management: diabetes, heart failure management, and smoking cessation. Let's start with diabetes. Did you know that physicians can earn up to $25,000 of additional yearly revenue by optimizing their diabetic patient claims? Many physicians miss out on a huge chunk of this revenue by not keeping up with the three main billing codes: K030, Q040, and K029. As these codes are out of basket, physicians are paid 100% of the value, and therefore more important that you are billing these on time, at the right time, and with ease. Here are the billing codes that physicians will be billing for diabetic patients. The Diabetes Management Assessment Code, or K030, is a fee claimed by the most responsible physician for continuing management and support of a diabetic patient, and is billable up to 4 times per year. This code requires a lab requisition for blood work, as well as completion of the diabetic flow sheet, which is also available for download on our website. The Diabetes Management Incentive Fee Code, or Q040, is payable to physicians who provide ongoing management using a planned care approach, consistent with Diabetes Canada's guidelines. The incentive code can be billed upon completion of 3 K030 assessments within the last 12 months and is billable on an annual basis. And lastly, the Insulin Therapy Support Fee Code, K029, is payable to physicians who provide support and counseling on intensive insulin therapy, requiring at least 3 injections per day, or using an infusion pump, or training on insulin for patients who use glucose meters, insulin pumps, or insulin pens. Similar to K030, this code requires the completion of blood work and a diabetic flow sheet. The fee code is limited to a maximum of 6 units per patient per 12-month period. Please note that the K029 is a time-based code, unlike the K030, and the K029 cannot be combined with the Q040 incentive code when billed. We get a lot of questions from physicians regarding whether you can bill their diabetic visits virtually. The answer is yes, you can. However, it's important to note that the first K030 billed for a patient in each 12-month cycle must be for an in-person visit. If it's not, the claim will be rejected and the assessment will not count towards the management incentive fee code. Moving on to the second chronic disease, congestive heart failure, or CHF. When managing patients with CHF, it is important to understand billing procedures. The CHF Management Incentive Fee Code, Q050, is an incentive payment to family physicians for providing comprehensive, guideline-based care to patients with CHF and can be billed once per year for enrolled patients diagnosed with heart failure. The code may be submitted separately or in combination with other fee schedule codes for a rostered patient, and it can also be billed without a patient visit on the same service date. Please note that prior to submitting the Q050 code, it is required to have at least 2 patient visits with the 428 heart failure diagnostic code in the previous 365 days. These visits can be either in person or virtual. Billing the Q050 requires completing a flow sheet and attaching it in the patient's permanent records. Here are some best practices for effectively managing the care and billing of your congestive heart failure patients. Firstly, identify your CHF patients. You then need to book 2 visits with each of these patients when you plan on assessing their CHF, and make sure you bill using the 428 diagnostic code. For example, a patient can come in and you bill an A007. You just have to include the 428 diagnostic code. Lastly, after the second visit has been paid by OHIP, pick a date when you update your patient's heart failure flow sheet and bill the Q050. To maximize your earnings, it's best to complete the flow sheet during your scheduled FO after hours, so you can add the Q012 after hour fee to your claim, which will be discussed later in this webinar. If you would like to download the congestive heart failure flow sheet, it is available on our website in the resources library. Smoking cessation is another area where you, as physicians, can enhance patient care and billing through structured patient support. When managed effectively, smoking cessation management allows physicians to bill 3 incentive fee codes, the E079, the K039, and the Q042. The E079 is billed for the initial discussion of smoking cessation with the patient. It is an add-on code that is only eligible for payment when rendered with certain billing codes, such as the A001, A003, A007, and more. The most important requirement is that you must document the discussion in the patient's medical record using a flow sheet that aligns with best practices. E079 can only be billed once per patient, regardless of their enrollment status, for a 12-month period. The K039 is the smoking cessation follow-up visit. This code can only be billed after the initial discussion, which happens after the E079 is billed. Please note that there is no specific time requirement for the K039, So it is one of those K codes that doesn't need to be 20 minutes, but you will need to document what is discussed, and it must be fully dedicated to smoking cessation counseling. K039 is limited to a maximum of 2 services in a 12-month period following the E079. When adding the Q042 smoking cessation counseling fee, you typically can apply it to the K039 follow-up visit code. This provides an additional incentive for a physician to offer counseling sessions to rostered patients that are smokers. Keep in mind that if you bill it for a non-rostered patient, it will not be paid. Similar to the K039, the Q042 add-on must be billed within the 12-month period following the service date of the E079 and is limited to 2 in a 12-month period. Now let's move on to some other common out-of-basket codes, and we'll start now with palliative care. In addition to long-term care codes, physicians can bill codes for patients who are considered in the palliative stage. The codes must be billed by primary care physicians when billing for palliative care are the following. The Palliative Care Support Code, K023, is a service payable to physicians for palliative services provided in the office or at home. Please note that the K023 is a time-based code that requires at least 20 minutes service to be paid. To be paid accurately for the service, please remember to document start and stop times. This service can be done in person or it can be done over the phone. The Palliative Care Case Management Fee, or G512, is a case management code you can bill when you provide supervision of palliative care to a patient for a period of 1 week, starting at midnight on Sunday. Providing this service includes elements such as monitoring the condition of the patient, ordering tests and interpreting test results, having discussions and providing telephone advice to the patient or their family members or representatives, as well as arranging for assessments, therapy, and coordinating community and hospital care. And finally, we have the A945 Palliative Consultation Code, which you would bill if another primary care physician referred the patient to you for further support. The minimum time required here is 50 minutes, 50. Prenatal and postnatal care are essential services that involve a series of visits and assessments aimed at providing consistent and timely care throughout each stage of the pregnancy journey. Having accurate billing knowledge in this area helps ensure the care you provide is properly documented and compensated. There are 4 main codes physicians can bill for prenatal patients. The first one being P003, the prenatal major visit, which is a prenatal general assessment that includes a full history, an examination of all parts or systems, and advice to the patient. This can only be billed once per pregnancy per physician. The second code that physicians would bill is P004, the prenatal minor visit. This code includes all subsequent visits for pregnant patients. The number of times this is billed is unlimited. P005, the antenatal preventative health assessment, which is completed by the most responsible physician for antenatal risk, examining all current psychosocial, genetic, and medical issues affecting antenatal risk. This can be billed once per pregnancy per patient and will reject if another physician has already billed for it. And lastly, P008, postnatal care in office, which is an intermediate assessment where the doctor will check any postnatal recovery and address issues such as infections, wounds, breastfeeding problems, and so on. It can be billed in the first few weeks after delivery for an unlimited number of times, as long as there's a justification for it. We recommend billing the P003 major prenatal visit and P005 antenatal preventative assessment on the first visit to ensure that patients' major assessments are completed and to provide the best care. Our team can generate a list of patients for physicians who have missed billing P003 or P005. Let's switch gears and talk about one of our last out-of-basket codes, the Q888. The Q888 is a weekend access fee code that allows physicians to bill for services provided to their groups enrolled patients for unscheduled visits on Saturdays, Sundays, or holidays. Some billing requirements include the patient must be enrolled in the FO group of the billing physician. The service provided is unscheduled and in person. Virtual visits by phone or video cannot be claimed as QAAA. The billing physician must offer at least 3 scheduled visits for each 3-hour Saturday, Sunday, or holiday block. The QAAA is applicable for enrolled patients only. Services provided to unenrolled patients during this block would use the most appropriate fee code as per the schedule of benefits. In addition, the QAAA code is an out-of-basket code, so the physician will receive the full amount submitted. Looking at the difference between QAAA and AAA codes, the question we receive the most is, what is the difference here? With AAA, you are not allowed to have any patients scheduled. The office will have to operate as a walk-in clinic and accept patients with time-sensitive matters, considered an emergency department equivalent. The Q888 allows physicians to schedule patients, and they can bill the Q888 for seeing unscheduled enrolled patients, provided that 3 appointments were booked or 3 slots were reserved for scheduled enrolled patients. Therefore, physicians should not bill the AAA during required weekends or holiday after-hour clinics. When the minimum required weekend after-hour blocks have been met, AAAs can generally be billed. Another question we often get is, when do I bill the QAAA code? Here is a table summarizing when you would bill the QAAA on the weekends and holidays as opposed to the AAA. As you can see, for specific types of patients, there are certain codes that you can bill for required weekend after-hour blocks and weekends once the after-hour blocks are met. We mentioned in our previous webinar that FO physicians are required to work after-hour blocks. To recap, these blocks must be a minimum of 3 hours each. Depending on the size of the FO group, physicians would likely work on 1 block a week or less, distributed throughout the group. That being said, let's dive into the after-hours premium that doctors would bill during these blocks in addition to their patient visits, the Q012. The after-hour premium code Q012 is a frequently unoptimized billing code. Many doctors miss out on additional revenue simply because they're unsure of when this premium applies during their workday. Q012 is utilized for enrolled patients seen during regular after-hours services held after 5 p.m. on weekends or on weekdays or any time on weekends or statutory holidays. You as a physician can earn a 30% premium on the values of the following fee codes that you can see on the slide for in-person or virtual care for scheduled and unscheduled services provided during your after-hour coverage. Now that we've covered the most common billing code areas in a FO, let's discuss some very common error codes physicians are encountering. The ministry's error report can often be unclear and confusing, making it hard for physicians to identify and address issues. Understanding the reasons behind rejections is key to resolving billing errors and protecting your practice's financial health. Physicians can expect to see two kinds of alphanumeric errors in their monthly reports sent by the ministry. There's three-digit error codes, like an EH2, and these error codes are found in the error reports sent by the ministry. There's also what's called two-digit explanatory codes, like an M1. These are error codes found in your remittance advice. Let's go through some common error codes that we see when physicians bill the codes mentioned earlier. First off, the EH2 error code indicates when a version code is invalid. In order to fix this error, you must verify that the version code is correct and up to date, and then you can resubmit the claim. The next code we often see physicians received is the M1 code, which indicates that the maximum fee allowed or maximum number of services has been reached. To fix this error, you must resubmit an alternative fee code or choose to write off the fee code if there is no applicable alternative. Lastly, the D3 error code is received when the service fee code is not allowed in addition to the visit fee. This code is dependent on the specific claim that you submitted. You must review the code payment rules in the schedule of benefits and fix or settle the claims accordingly. Now that we know what the most common error codes are, let's look at some real examples and when they occur. So you see a patient for their regular scheduled diabetic visit. You bill the K030 diabetic code that we went over before, but you receive an M1 error code on your RA. How do you fix this error? M1 indicates that the maximum services have been reached, meaning the K030 was already billed the maximum number of times, which, as we covered before, is 4. You would resubmit this claim with the most appropriate alternative visit code, like an A007. As we arrive at the end of this webinar, let's go through some key takeaways from today. First off, the FOE model is changing. Physicians will receive additional compensation for direct and indirect time spent with patients, as well as an increase in shadow billing and many other premium and procedure codes. Physicians will also no longer receive penalties for outside use with patients, which is a major change. With the updates to the FOE model, it is more important than ever to ensure not only that what you're billing is correct, but also that you're maximizing your billing potential by utilizing in-basket and out-of-basket codes. Chronic disease management billing continues to be one of the biggest points of billing optimization, yet physicians are not maximizing their potential. Making sure that you are tracking your patient visits and billing your management fees at the right time is key to maximizing your revenue. A big thank you for everyone attending today's webinar, and we would like to extend this exclusive offer to all our webinar attendees. For a limited time, we invite you to book a complimentary billing assessment with one of our expert team members, where we will do a complete review of your medical billings to identify challenge areas and opportunities for improving your processes. You can contact us today at the email info@doctorcare.ca to get started. Additionally, as mentioned at the start of the webinar, to thank you for attending our webinar today, all participants will receive a free copy of our new 2025 OHIP billing guide via follow-up email. So make sure to keep your eyes on your inbox. So, as promised, we'd like to open the floor for your questions. Please feel free to submit any questions you have using the Q&A feature, and we'll probably take a few minutes now to answer a few questions. As mentioned at the start of the webinar, if we can't get to your questions, then we will follow up with an email. So the first question here that was passed along to me If a patient was referred to me for an HPV test, as we spoke about before, that new HPV testing, can I bill an A005, so the consult code that we spoke about earlier, in addition to the G365? A reminder, the G365 is the HPV testing code, and the E430, as a reminder, that's the tray fee add-on code for doing the testing outside the hospital. So it's a good question, but no, if you are billing an A005, that will cover the G365, the HPV testing code. So you can't bill those two in conjunction. You would still be able to bill that tray fee with the A005, but you would not be able to bill for the G365 as that's included in the services there. Um, we've had a few questions come through about tracking your diabetes, KO30 and QO40 billings there, and how best to get help with this. So Doctor Care has a bunch of strong offerings here that can help optimize revenue there. We have our offering called Patient Care that provides monthly diabetic recalls to patients, monthly or quarterly, depending on how frequently you'd like it. And it creates a customized plan to really include patient reminders and announcements. That's one great way of doing it. If you're looking for support, there's potential reports we could try and generate within the EMR as well as our practice care report will outline all of your diabetic patients that are due for a recall. So there's loads of ways that we could help, and we'd be more than happy to chat through them if you want to reach out to us. Another one here is asking if you can bill a minor assessment if all you're doing is refilling a prescription. So strictly sending a prescription refill to a pharmacist. And the truth is there you can't. A001 does require you to do an assessment of the patient, and billing a prescription renewal is actually considered an uninsured service. So a service that is not covered by OHIP and can be billed directly to the patient if appropriate. I'll take one more question here before we hop off, and then we're happy to follow up after. One last question is if you can bill prenatal or postnatal codes virtually, has been shared with me. So most of them, the answer is no. The only one that can be billed virtually is the P005, that antenatal preventative assessment that we spoke about. But it is recommended that for the P003, the full history, the P004, those are assessments that are expected to be done in person, and therefore you can't do that over the phone. So to wrap up, we hope you found our webinar very useful and really thank you for attending and for listening. On behalf of Doctor Care, we appreciate so much that you joined us today. If you have any questions or feedback on this webinar, feel free to contact us anytime. Our contact information is listed on this slide, info@doctorcare.ca, and we hope everyone has a wonderful day. Thank you so much.